All right. So welcome to Neuropathology Conference this morning. Hope everybody can hear me. We'll get started since we have some case presentations for the second half here. So first case, Seth, are you on? Seth, are you there? If not, let's go to Long.
Hey, Damien, I'm here.
Hey, Long. So first case here, 53-year-old male, history of a lot of comorbidities. Kind of some of the highlights are diabetes with diabetic retinopathy, adrenal insufficiency, AFib. He has a pacemaker. So overall, pretty sick, complicated guy presenting to Bascom with 3 to 4 days of blurry vision and quote floaters in his eyes, and 2 to 3 months of intermittent frontal headaches. Was initially worked up at Bascom. Of note, he's also got a history of chronic sinusitis, chronic skin problems. He's on prednisone. His exam is there, not anything too remarkable, and his visual acuity is actually pretty good, but he does have some evidence of papilledema. So you have this patient kind of, sort of interesting story. What additional workup would you want?
Yeah, I'd probably just start off with a CT head, given evidence of papilledema, and then what was his prior surgery that caused the nystagmus?
He has had like ophthalmologic surgery, nothing intracranial. He has a bunch of ophthalmologic issues, kind of a baseline.
Okay, got it. Thank you.
Yeah, so CT wasn't actually done. I was thinking more in terms of kind of, CT brain wasn't done. We'll get to kind of what the intracranial findings are, but we're thinking sort of more like an inflammatory or some sort of other kind of process that might be causing this. CT, let's say the CT was, negative. We're trying to figure out what's going on with this guy. So these are some additional workup measures you can think. He had a CT chest and pelvis, showed osteolytic lesions at T8, T12, and a pathologic L2 compression fracture. And so he then underwent a CT guided bone biopsy, the L2 lesion, but that was actually negative. Also had all these other markers, RPR, Fungitel, looking for any sort of inflammatory and or infectious process, and his IgG levels were all normal. So this will kind of come into play as we get into the actual case. But an MRI was done. That was sort of what Bascom had ordered. Kind of they go to ophthalmology to get an MRI. It's usually the standard. So what do you see here on the imaging?
Yeah, so it's a T1 non-con, T1 with contrast, and T2 flare all axial. I see enhancing looks like pachymeningeal enhancement, with also looks like an enhancing dural base lesion on the left. There's also appears to be some flare, hyperintensity on the left temporal lobe, on the right.
Good, yeah, and exactly. Pachymeningeal enhancement is what in the middle image is what we're looking at. What we want to focus on. Here's some more images. If you can kind of just describe what you see here as well.
So again, demonstrated as the left dural base lesion. There's some mild ventriculomegaly as well. There's also evidence of some enhancement in the sinuses. And then also it looks like a enhancing temporal, like cystic temporal lobe lesion on the right, and then also intraorbital lesion. Cystic enhancing temporal lobe lesion on the left, as well as an intraorbital lesion on the left.
And what is this kind of looks like? What is this kind of structure here that looks like this is arising from?
Yeah, I think it's probably coming from the tent.
Mm-hmm. Yeah, exactly. So kind of still dural based. And then there's another one here in the right temporal lobe as well. Kind of same sort of idea arising from this temporal lobe dura. Good. So that's our imaging. What do you think, kind of based on this, might be going on with this guy?
Yeah, I think given
Differential.
his evidence of metastatic disease, I think probably top on my differential would be probably like a dural based met. Other things I would include on my differential would be multiple meningiomas, although that's less likely, and then like some autoimmune inflammatory etiologies like histiocytosis, as you mentioned. But I think top of my differential will probably be dural-based meds.
And how about any other what other like kind of like great mimicker that kind of can look like anything in terms of that might be more of an oncologic diagnosis?
Like lymphoma?
Yeah, that could be one as well. And then what about, are there any specific infectious etiologies? You mentioned like the inflammatory ones, but anything like you would be concerned about infectious wise?
Are you thinking like TB?
Yeah, I mean, yeah, TB, fungal infections, things like that. Again, a little bit less common, but can still kind of present with these sort of, odd infectious, inflammatory type lesions. Good. So yeah, dural based meds, I agree, kind of looks like, multiple lesions. He's got these, lesions in the spine, thinking dural based med, lymphoma, sarcoid, you said, the inflammatory disorders. Granulomatosis with polyangiitis is GPA. That's another one that can potentially present like this, although it's pretty rare to have intracranial involvement. And then meningioma, like you said, again, less likely, but could potentially be there still given the multiple lesions. So I guess before we get into that, what would you recommend? From a neurosurgical standpoint, now what would be your next steps? So you have all these imaging and all those lab values I showed that were all completely negative. No one really knows what's going on. What would you recommend?
Yeah, I think he needs tissue for pathology. So I would probably, I think the left convexity, dural-based lesion would probably be easiest. So maybe like a left craniotomy for open biopsy of that lesion.
Good. Yeah. Exactly. So that's exactly what was done. They did a left frontal cranium. They biopsied the dura. And now we'll get into the pathology of what it actually showed. Dr. Gultekin, if you're
yes, you hearing me?
Yes.
Okay, great. So you're looking at two images here. On the left side, I gave you an overview of kind of a patchy involvement of the connective tissue. The connective tissue is pink, and the clusters of cells that you see here turn out to be, on the right image, necrotizing granulomas. In the center of the right image, you see individual cells that are undergoing apoptosis, necrosis, and it is surrounded by an array of viable cells. Next slide, which turn out to be histiocytes by CD68 staining. So you can see on the left a beautiful picture of a necrotizing granuloma. You see the center is necrotic, and it's surrounded by histiocytes, macrophages, and maybe a variable number of other mononuclear cells, such as lymphocytes. On the right side, we attempted an IgG4 immunostain to get the IgG to IgG4 ratio, to rule out or rule in the IgG4 related pachymeningitis. There are some IgG4 labeling cells, plasma cells, as you can see in the center. Those chocolate dark round cells are IgG4 carrying plasmacytes. But Dr. Saad Sainout was equivocal about the ratio, and I looked at it myself. I didn't think that there was a very strong evidence of prominent reversal of the IgG4 to IgG ratio in that biopsy. Anyway, the diagnosis is necrotizing granulomatous pachymeningitis. The special stains for microorganisms, fungal stain, and acid-fast bacilli were negative. There is no evidence of lymphoma or meningioma or metastasis.
Great, thank you. So, obviously a very interesting case. Kind of nothing really seemed to quite fit. We'll get into kind of what the necrotizing granulomas could potentially be, but just a kind of a quick difference between the pachymeninges when we talk about pachymeningeal enhancement versus leptomeningeal enhancement is an important difference, and that comes down to the specific layers of the actual meninges. Obviously there's three: dura, arachnoid, and pia, but there's actually an outer arachnoid layer, which is one combined in discussing with the actual dura, is the pachymeninges. And then if you're talking about the leptomeninges, that's the pia and inner arachnoid layer. And so the differentials, kind of differ for each of those. Pachymeninges, things like infection, intracranial hypotension, or certain inflammatory disorders can be seen in neurosarcoid, rheumatoid, GPA, as I mentioned earlier. And then if we're talking about leptomeningeal enhancement, often that tends to be either meningitis, encephalitis, leptomeningeal carcinomatosis. Can also be lymphoma or vasculitis, and there's a number of other differentials as well. But that's sort of an important difference to remember, not something that I quite understood, especially this early on. So with respect to these pachymeningeal necrotizing granulomas, as Dr. Gultekin described, the dura had dense fibrosis, histiocytic proliferation, and these caseating necrotizing granulomas. And so that tends to raise the possibility of an infection process, things like TB, where there's this chronic granulomatous response limiting the extension of inflammation. It activates histiocytes, forms this rim of histiocytes and a GON complex or GON focus around this necrotic setter. Necrotizing granulomas can also be seen in granulomatosis with polyangiitis, and there typically is a vasculitis component to that as well. Often commonly occurs more in the lungs than it does intracranially. And then there's a number of fungal infections, Cryptococcus, Coccidioides, Histoplasma, that also are all associated with these granulomatous processes. In our case, a little bit odd that none of these kind of seem to fit. And then, as Dr. Gultekin mentioned, though, another possibility is that because there is an increased number of the IgG4, it raises the possibility of an IgG4 related disease. And this is an increasingly recognized systemic fibroinflammatory disease characterized by tissue infiltration of IgG4 plasmacytes. And kind of in just looking up more on the topic, failure to accurately diagnose and treat it can allow for disease progression, ultimately lead to permanent organ dysfunction. And the greatest barriers to diagnosing it include lack of awareness. It's a relatively uncommon disease, especially for us as neurosurgeons, and it can imitate many better recognized systemic conditions, which sort of seems like that's kind of what happened in this case. And it's still unclear whether this is truly an IgG4 related disease, as all his immunoglobulin levels were all kind of within normal limits, and additional workup was all negative. I did find this paper, though, that looked kind of eerily similar. This case report, there's not too many out there of spontaneous necrotizing granuloma within this case, the cerebellum, but the kind of dural pachymeningeal enhancement looked actually relatively similar to the ones in our case. And essentially it was in a 77-year-old with a history of, sinusitis and some other testing. They did all the testing, ANCA, everything was negative. And so they ultimately determined that it was just a spontaneous case of these necrotizing granulomas within the pachymeninges, which is a very rare entity. So perhaps maybe that's another etiology, that this was just purely spontaneous, but kind of remains to be seen. But nonetheless, a pretty interesting case.
Was ANCA done on this patient?
Yes, everything was negative that I was able to see in the.
And no evidence of rheumatoid arthritis,
not that I
rheumatologic disease.
I saw in the history.
Dr. Shah is indicating that he had a remote history of histoplasmosis of the lung. Well, I don't know how that connects, but we didn't see any fungal organisms. Was there any culture sent?
I don't know if there are any cultures intra-op. I know we had like histoplasma, antibodies, serum antibodies that were sent. That again, everything was negative on all the laboratory data within, that I had seen on his admission, but that perhaps maybe within the tissue.
Yeah, another thing is IgG4 disease is a systemic disease. It may be isolated in the CNS, but generally you will find in other organs too, if it's present. And I think in this case, he was negative, right?
But he has orbital involvement and his bones are involved as well.
Oh. Yeah, in that case, I don't know. How about sarcoidosis? Was there any evidence of sarcoidosis? ACE levels, pulmonary lymphadenopathy?
I think he might have had some pulmonary lymphadenopathy on that CT chest, abdomen, and pelvis. They noted some nodules that could have been potentially sarcoid, but again, I think his like ACE levels and everything were all negative. Now, I don't know what, maybe those, if you still have normal laboratory values, but imaging and other clinical characteristics that could still point you in that direction without confirmatory laboratory testing. But
So high dose steroids rule out infection and then give steroids. Is that what they're gonna do?
Yes, currently he's on steroids and
Okay,
just trying to. And I think we sent his panel to Washington State for infectious workup.
excellent. Thank you.
But I think leading diagnosis, I think, is IgG4 pachymeningitis, but
Could be. Could be.
just based on his history and the orbital involvement.
okay, but yes, very very interesting case to start out with. So next case here, let's see who's on. Is Seth on now?
Hey, sorry. Can you hear me?
Yep. Hey, Seth.
Sorry. Yeah, I'm just having connection issues here. I think I'm good to go.
All right, no problem. I can hear you. So case 2, a 53-year-old female presents in a wheelchair with 4 months of left-sided neck pain and radiates into her trapezius. She also reports numbness below her umbilicus and intermittent electric shock type sensations on her left hemibody. And notably, she reports worsening leg weakness and heaviness with progressively decreased ability to ambulate over this time. So her exam is here. Obviously, you can see significant, primarily left-sided leg weakness, basically barely able to move the left leg at all. She has a T10 sensory level. And what do you think about the reflexes, Seth? Does that sort of fit with kind of her overall picture that she's describing? What do you think might be going on in terms of her where
Yeah,
her pathology might be?
Yeah, so she's coming in with a wheelchair. What is her baseline?
Normally able to ambulate. Basically, in the last 4 months, has become progressively paraplegic.
Got it. Okay. And then she has increased reflexes of the lower extremities.
Mm-hmm. So what does that the increased reflexes tell you about where you think the lesion might be?
The central.
Sure. What do you mean by central?
Oh, sorry. Sorry.
Is this upper motor neuron or lower motor neuron?
Yeah, upper. Sorry, upper.
Okay. Yeah, exactly. So we're probably going to be looking at somewhere in the spinal cord or within the brain. But did have a negative Hoffman's and negative clonus, but still hyperreflexive with the sensory level is obviously very important, and she's nearly paraplegic in that leg. So what do you see? So patient comes in, needs an MRI. They came in with an MRI. Actually, I think they were seen in clinic. But what do you see here on the imaging findings on this MRI?
Yeah. So on this T2 sagittal, there's some a lesion around I think T1. It looks on the axial. It looks intradural. I think intramedullary.
Yeah, it's a little hard to tell on the
Hard to
axial.
tell for
How about
me,
if you
yeah.
look? How about if you look on the sagittal and you see the spinal cord here? What do
Yeah.
you
Okay.
think based on
Extramedullary.
this?
Yeah.
Good.
Yeah. Like the
exactly.
anterior to the cord, and yeah.
Okay. So any other sequences you want to look at? What do you think this might be? This is just a T2 here. So anything else you want?
Yeah. Maybe look at with contrast.
Yep. Okay. So the top left, what's the image all the way on the top left?
Top left is T1
Uh-huh.
and T1 sagittal, and then post contrast in the top middle.
Yeah, exactly. And so And then the bottom right are all just post contrast images, kind of just looking at different slices in the axial plane. So what do you see on the contrasted images? How would you describe that?
Yeah, it looks like a contrast enhancing lesion. Uh, um, and it looks sort of heterogeneous contrast enhancing. I think there's this like central sort of core to it.
Good. And would you say it's pretty well circumscribed, kind of diffuse, infiltrative?
Well circumscribed.
Good. And then you can see sort of here as well in this axial image. What do you kind of think this contrast, like, what do you think this could be a component of, kind of coming out here?
Extending through a foramen, maybe.
Good. All right. So taking all this together, what do you think differential would be for this type of lesion here?
Yeah, so intradural extramedullary differential would be something like a meningioma or a neurofibroma, maybe a schwannoma.
Good. Yeah, those three are the definitely the highlights. All right. So other things that less likely could be a solitary fibrous tumor, a malignant peripheral nerve sheath tumor would be even more unlikely, unless they had like a neurofibromatosis or some other kind of systemic disorder. But yeah, good. You hit the highlights. So neurofibroma, schwannoma, meningioma are the three most common. And we'll get into kind of which are the specifically the most common. So what would you recommend to take care of this patient?
Yeah, I think I think this will most likely need to come out. And in terms of how we would approach it,
can you come from the front? You can come from the back. What would you say based on the location?
Yeah, I mean it's interior, so maybe an anterior approach would be good here, but it's at E1s, so I guess I'm not too sure what our lower limits of an approach from the interior is.
Lower.
Pardon me?
I'm sorry, go ahead.
Yeah. Yeah, I agree. So this is going to be very low, hard to get kind of from an anterior approach, especially to kind of resect this through the front of the spine. So what would then?
And then I guess if we go posteriorly, then we're going to have to sort of I think manipulate the cord a little bit to get around to the front of it.
Yeah, to a little bit. You can see here it comes, it's more eccentric to the right, but does come kind of just underneath the lamina here. The spinal cord's pushed pretty far over to the left. So still accessible. You can debulk and can still safely take this out from a posterior approach. So that was what was done. Just kind of a side note, what things, if you're okay, so say you're okay, we're going to do a laminectomy for intradural extramedullary lesion resection. What are the things that, if you have to book the case, what kind of some special considerations you would want for this case?
We'll go for a microscope, probably have like motors and
neuromonitoring. Yep, good.
Neuromonitoring.
Yep. And then anything else that you would want to know, kind of a special thing that we would use once you've done the laminectomies and you're trying to decide if you need to drill any more, remove any more bone, or you can just start opening dura and going after the tumor. Anything we might use?
Would we use like ultrasound at all?
Yeah, exactly. Ultrasound. Yeah. So it's very, very common just to know your kind of superior and inferior extent of the lesion. Make sure you're above and below it before you open the dura. And then same if in this case you'd want a Mayfield, you'd have to pin the patient, make sure everything is secure, make sure that micro instruments, et cetera, all in the room, all that stuff. Kind of just things to kind of consider as you're start booking these cases, as your own call. So now we'll go back to Dr. Kultekin for the pathology.
Yes. So Low power picture on the left shows a moderately cellular tumor with a collagenous background, and notice that the pattern is not very obvious, like a patternless proliferation, and it's pretty much monophasic. On the right side, you see these cells turn out to be low-grade looking spindle cell elements, again with a dense collagen background. And sometimes there are these rare atypical looking cells on the sort of the left 1/3 upper part. There's this big cell that stands out. Yeah, exactly that. And otherwise, you don't see any, meningothelial like elements like some MoMA bodies, whorls, pseudo inclusions. You do not see schwannoma like patterns such as Verroque bodies or Anthony A, Anthony B. And this would turn out to be a neurofibroma. Special stains, next slide, I believe. Yeah, so it is SOX10 positive. SOX10 is a transcription factor. It's a very good nuclear marker for peripheral nerve sheath tumors. If this is positive, like it is right now on the left, you rule out meningioma essentially. On the right side, there is epithelial membrane antigen, EMA, which is a traditional marker for meningioma. It's very weak and focal. So neurofibromas consist of Schwann cells, fibroblasts, perineurial cells. So the staining is heterogeneous by nature, but you don't see collagen type 4 or reticulin individually surrounding tumor cells. As you know, Schwann cells have basement membrane, and a schwannoma would be, positive in that regard with reticulin. So this is a neurofibroma, benign WHO grade 1 with no MPNST component.
Okay, great. Thank you. So as Dr. Gultekin said, neurofibroma, it's benign grade 1 peripheral nerve sheath lesion, although less common within the spine that we see compared to meningioma and or schwannoma, of those three that we mentioned at the beginning. Often patients with the nerve root tumors can have neurofibromatosis. Often neurofibromas are associated more with NF1, and then schwannomas are associated with NF2. Think like bilateral acoustic schwannomas in the NF2 patients, that they can get schwannomas elsewhere in the nervous system. In NF1 type patients, often multiple lesions are common. They not just in the spine; they can have them, cutaneously within the skin as well as part of the diagnostic criteria. And then imaging characteristics on CT, they're well-defined hypodense mass. They can enlarge a neural foramen, which schwannomas can also and have that dumbbell appearance, so they can't always be teased apart based just on imaging characteristics alone. On MRI, they have this T2 hyperintense rim and the central area of low signal, this target sign that can be seen, and that's due to a dense central area of collagenous stroma. As Dr. Gultekin mentioned, and Seth, I think you pointed that out as well, kind of that sort of heterogeneous enhancement with that sort of target sign appearance on there is pretty characteristic of fibromas as compared to schwannomas, which often tend to look a little bit more cystic. And treatment is surgical resection for symptomatic lesions if they're asymptomatic. Obviously, that wasn't the case in our patient here, but they are often difficult to dissect off the parent nerve root because they arise from and encase the nerve as in comparison to schwannomas, which tend to just displace the nerve. And then about 5 to 10% can undergo malignant transformation, particularly if there's an association with NF1 or the plexiform type neurofibromas. And then one final question here, Seth, for you, kind of based on what I just mentioned here. Picture A and B. So which would you say, what A or B would be the neurofibroma lesion compared to a schwannoma? So is A the neurofibroma or B the neurofibroma, based on what I said about kind of how they arise?
Sorry, I think B be the neurofibrillary.
Good. Yeah, exactly. So it's arising kind of from the nerve. It's often very
Yeah.
difficult. You can see there's no real plane. It essentially is part of the nerve, whereas the schwannomas tend to grow kind of and displace the surrounding fascicles of the nerve as they grow out from the Schwann cell itself, not from the actual nerve tissue.
You can see that on B, axons are going through the tumor. And we can demonstrate that by neurofilament stain. We use it as a diagnostic tool, actually, in that the nerve axons are actually penetrating the neurofibroma in that case. Whereas schwannoma arises from the outside, from the nerve sheath. So it pushes the nerve, doesn't really penetrate or infiltrate the nerve. What was the operative findings in this case? Like in terms of, relationship of the tumor to the nerve root.
I can't recall specifically based on I wasn't in the case myself, but
Okay.
yeah, I'm not sure exactly. I'm sorry.
Mm-hmm.
All right. So case 3, Vadia, are you on? How about Mod?
Yep, I'm here.
All right. So case 3 is a 50-year-old male, no past medical history, presented with 3 years of dizziness and frontal headaches. Also noted some gait imbalance, difficulty ambulating, and decreased dexterity in his right hand. Here's his exam is unremarkable. He's intact. Let's say CT scan was negative. What would you want to evaluate? This guy comes to your clinic.
CT scan is negative, and then so he's just having some kind of generalized symptoms. It sounds like just frontal headaches and some gait imbalance. Okay. The decreased dexterity in his right hand is kind of, and the difficulty ambulating almost sounds kind of myelopathic. So I'd be worried maybe about something in the cervical spine. If it's higher up in cervical spine may kind of also contribute to his headaches and dizziness. I'd probably get MRI C spine or CTC spine, and then depending on what findings show.
What about the headaches and let's say his headaches and the dizziness are kind of worsening? Those are his main complaints. Would you get anything? Would you get any?
Yeah, maybe just MRI brain also, just kind of rely on anything underlying the CT would have missed, obviously, but yeah.
Good. So there we go. Okay. So here's the MRI. What are you looking at here?
So on the left looks like a T1 without then T2 looks like a T1 post in the middle, and then I want to say, let's see, I'm assuming there's a diffusion on the right,
No.
flare.
Just a T2.
Yeah,
CSF here is
T2.
hyper intense. Okay, so what describe kind of what you see between the sequences here?
Yeah, so he has kind of like this iso intense signal right just anterior to posterior fossa, kind of anterior to cerebellum. It looks consistent with CSF. It's not contrast enhancing. Questionable whether he has kind of like maybe like an arachnoid cyst or some kind of other cystic lesion. It looks like he also has like on the post-con is a little bit more obvious, but it looks like he has some either septations or kind of like a membranous kind of component to it as well. So I think it kind of looks a little bit more concerning for arachnoid cyst. There's obviously some mass effect on the just a little bit, but nothing else that's really striking.
Do you think kind of what you're seeing this could explain his symptoms, like what you're saying
Yeah,
before?
it could definitely be kind of explaining his symptoms, but I mean, I'd be interested to also see if there's any component of hydro. I don't think so, just because I mean it looks like it would be communicating, but can definitely contribute to his gait imbalances.
So
Sure.
now, so what do you see here? These some additional sequences and cuts.
Yeah. So on the diffusion, some restriction in diffusion imaging, but nothing obvious on the flare on the right.
What do you think about his ventricular size?
Yeah, I mean, I think it looks mildly dilated. Well, I mean, his temporal tips are definitely prominent. So
And then what do you
some element of
call
hydrocephalus.
this sort of
Yeah, he has
kind of edema around
transepithelial flow
Mhm.
on the MRI as well.
Exactly. And so how do you know that you said that this is restricting? How do you know that this is restricting here?
You could actually,
not
like,
just-
if I'm looking at it, actually, I'm now thinking it's more T2 shine through because it's kind of bright on both the ADC and the.
Yeah, it's a little bit. I mean, it's still
A little
it's
bit.
a little bit darker here. I agree. I was just kind of saying. So you have, it's bright on on the diffusion, the DWI specifically, and then darker on the
ADC is a little
ADC.
darker.
Yeah. Okay, and then this is just to show you he does have some component of kind of some mild hydrocephalus, but again, this has been going on for several years now. And so what do you think might be? I mean, what would be in your differential will be highest on your differential based on the imaging and the kind of the history.
I think also possible abscess, but if there's any kind of depending on his other comorbidities. I think.
Do you think he'd be coming in your clinic and pretty healthy otherwise if he had an abscess like this size?
Probably not, but the other thing I would think of is like an epidermoid potentially, if it's since especially if it's just diffusion restricting on the MRI scan. Less likely thinking arachnoid cyst just because of the characteristics on here, but yeah.
Okay, yeah. So epidermoid cyst, dermoid cyst could be a cystic acoustic, but much less likely given there's no real enhancement. And then an arachnoid cyst as well, as you kind of mentioned initially, could be kind of all sort of in a differential. But as we'll get into, we'll see why there's definitely one leading diagnosis. So what would you recommend? What do you think should be done for this patient?
I mean, symptomatic. So, and especially with epidermoid being high as a differential, he should have resection. Obviously, with epidermoids, there's a high chance of recurrence within 6 to 8 years, basically. Arachnoid cysts, normally, if we're thinking arachnoid cysts, we don't really operate, but if they cause symptoms, like as they are in him, we still want to treat surgically. But yeah, we should treat surgically for him.
Okay. Good. And just kind of to save some time here for these presentations, we'll kind of go through. We'll skip ahead a little bit. So yeah, your right retrosigmoid craniotomy was what was done, and you need microscope, neuronavigation, neuromonitoring, all important things to consider. And now we'll go to the pathology.
Yeah. So on low power, you see a light pink cystic lesion surrounded by some kind of demarcating element. On the high power on the right, you can see that demarcation was actually squamous epithelium that is running in the middle of the slide on the right side, kind of obliquely. Yes, that's the squamous epithelium. And then the contents, this diffusion restriction, all that you were talking about, is this dead keratinocytes. You can see these strands of flakes of, keratinocytes that constitute the content of the cyst. So this is an epidermoid cyst.
All right. So as Dr. Gultekin said, an epidermoid cyst, relatively uncommon. Congenital lesions account for about 1% of all intracranial tumors. They result from inclusion of these ectodermal elements during neural tube closure, usually within the 3rd to 5th week of life. Derived from desquamated epithelial cells. They're often waxy or pearly in appearance, even intraoperatively. Typically present in middle age, just because they slowly grow over time, and then they start causing mass effect on adjacent structures, as was the case in our patient. very commonly arise either in a CP angle or paracellar, sort of more off kind of paramidline predominance. They, as we discussed, they mimic CSF on CT, which is initially why it was read as negative, and then MRI, except for DWI, it mimics CSF on MRI, except for the DWI sequences, which we mentioned, demonstrates restricted diffusion. So you want to definitely make sure when you're looking at these MRIs, you kind of check all the sequences, especially if you don't really see anything obvious, no big enhancing lesion. Always check the DWI to look for other sorts of lesions. And the tumors tend to encase the nerve and arteries rather than displace it, often making resection more difficult. So gross total resection of the tumor in the capsule is the ideal treatment, obviously, to prevent any recurrence or benign lesions. But often you're unable to completely resect them due to the adherence of the capsule to the surrounding cranial nerves, vascular structures. And so often tumor has to be left, or at least the capsule has to be left behind. Fortunately, they tend to be slow growing, so you can monitor for recurrence over time, but they often do come back. And then an important kind of caveat or thing to know about when you see patients with epidermoid cysts is Moller-Ray's meningitis is recurrent aseptic lymphocytic meningitis associated with epidermoid cysts specifically. They can get intracranial cystic pathologies that release squamous material resulting in meningeal irritation. That's thought to be one of the thought to be sort of the pathophysiology behind why these more cystic lesions within the brain can cause this type of meningitis. It's due to the squamous material that's associated with the epidermoid themselves. All right, so last case here, case 4 is Tyler on.
Yeah, I'm here.
All right. So last case here, 39-year-old female who developed 1 year of neck spasms, 1 month of burning left thumb and index finger paresthesias, denies any weakness, myelopathy, neck pain, any gallbladder dysfunction. She's full strength on exam, but does have some hyperreflexic left triceps and right knee reflexes, as well as a positive left-sided Babinski. So what would you want to do in terms of workup for her?
Yeah, I'd probably start with like an MRI C-spine, just given the neck spasms, the left finger paresthesias, and the Babinski. Okay.
Exactly. So what do you see here?
So T2 looks like a very large, either like I guess it looks more like a cystic lesion, intradural, intramedullary. Is there a contrast scan?
Good. Yep. Exactly. So
it's not really contrast enhancing.
Yeah, I agree. It's definitely not avidly contrast enhancing. There's maybe some faint kind of contrast enhancement sort of on the peripherally, but yeah, agreed. It's not avidly contrast enhancing. So what based on kind of the location here, what do you think the differential could be for this?
Like ependymoma. What else? Intradural, intramedullary. Could I mean, I would expect it to be contrast enhanced if it was like an astrocytoma or something like that. So and not cystic. What else is up here?
Anything else that sometimes often intramedullary and associated with cysts,
like
maybe in the spine or the brain?
Oh, like a palicytic, not palicytic astrocytoma. Not sure.
Hemangioblastoma.
Oh, hemangioblastoma.
Doesn't really quite look like this
Okay.
on imaging, but that's another cystic, intraspinal, intramedullary lesion. And then again, very rarely could be metastasis or any demyelinating or inflammatory pathology as well. And it's not avidly contrast enhancing. It looks, a little strange, not exactly quite like a tumor, but it could always kind of be that. So there's just something to kind of keep in mind before you say, oh, go in and biopsy. It could be, MS or something like that you obviously want to, rule out before you, go after any sort of lesion like that within the spine. So here's kind of our main things. As you said, ependymoma, astrocytoma would be the more common ones. What would you recommend for this patient?
Yes, resection. So for this, you'd want to go posteriorly. Pretty big. I mean, it extends from like 2 to three, four, so five, at least a little past five, really like the 5, 6 area. So at least like a C posterior C2 to 5 lammy laminectomy to access the space, and then you're going to have to do you have to fuse or put instrumentation rather, since it's that large of a surgery.
Not
No?
necessarily. Obviously, you want to be careful not to go, too far lateral and kind of disrupt, the facet joints and things. But more importantly, how would you access this given that it's intramedullary? When you make, let's say, you open the dura, how do you know where
So yeah,
midline
so you
is?
use ultrasound like we were talking about earlier to make sure you've exposed like the full margins of the tumor anteriorly and or superiorly and inferiorly. And then you usually split the it's where you look for where the blood vessels, the peel vessels dive in, right? And then that's where you can split the cord posteriorly, like enter the
Yeah,
cord
so
posteriorly.
your midline myeloctomy is going to be where the small peel vessels, as you mentioned, are kind of diving in the midline. Sometimes there's often relatively large veins overlying the dorsal spinal cord, but that's not always exactly in the midline, and you can see they kind of can weave and snake around. So you want to find the kind of small vessels that dive really right into the center.
Okay.
Good. So yeah, the C26 laminectomy for resection of the lesion was done. Again, same thing. You need ultrasound, microscope, neuromonitor, all that stuff. Mayfield. So next is the pathology for this lesion, Dr. Gultekin.
Right. On the left, you see a moderately cellular lesion. On the right side, you see a good example of a rosette in the center, a nuclear area surrounded by an intensification of nuclei in the center, upper center. And next, please. And the nuclei are uniform, round to oval, and low grade looking. On the left side, there's a blood vessel, and around the blood vessel, there's a nuclear free zone. So this is a perivascular pseudo-rosette, in that the cells are sending their processes to the blood vessel wall, creating that nuclear free zone around the blood vessel. That's pretty characteristic. On the right side, you see a rare finding where the tumor is forming ependymal surfaces, just like it's trying to form like a ventricular lining. Again, in the center upper area, you can see there's an epithelioid formation with regimented nuclei with some apical area. I mean, I don't see cilia here, but it really looks like a ventricular wall. So this is a classic grade 2 ependymoma.
Okay, great. Thank you. So the Gultekin said grade 2 ependymomas, most commonly the spinal ependymomas are WHO grade 2, except for myxopapillary, which this graphic's a little bit old, but myxopapillaries were reclassified to be WHO grade 2 now. So ependymomas WHO grade 2 account for about 3 to 9%. Can appear at any age, but so typically these ependymomas have this bimodal age distribution, either in young kids, particularly in the posterior fossa. They're more common in children, and then these spinal tumors, as the case in our patient, they're more common in adults in the kind of middle age, 30 to 50 years old. For histologic subtypes, cellular, clear cell, papillary, tansitic. And no or rare mitotic activity, these monomorphic nuclei, as Dr. Gultekin mentioned. And then you can have anaplastic ependymomas as well, which are WHO grade 3. Again, usually occur in infants and children. There's more marked hypercellularity and nuclear pleomorphism and much more mitotic activity, and they're much more aggressive and invasive as tumors themselves. And then regarding the spinal ependymomas, myxopapillary is also an important one to note. Account for about 10%, tend to occur more in young adults. There's usually less atypia or mitotic activity, and again, they're slow growing. And Tyler, do you know where these tend to arise from in the spine? The myxopapillary specifically. From the phylum. So they're often at the kind of at the end. The conus of phylum is where they're typically seen, pretty much always. So just a couple more things here as we're running out of time. They make up about 25% of intramedullary lesions. They're often present, as I said, middle age with no gender predilection. Symptoms are generally progressive over several months to years, and they can kind of be undetected for several years. They often include areas of cystic change, up to 60% of ependymomas that are seen, as well as they can have hemorrhage, necrosis, and/or calcification, which often points them more towards ependymoma rather than an astrocytoma. If you see calcification, tend to produce heterogeneous signal, hypointense on T1, hyperintense on T2. Myxopapillaries tend to more homogeneously contrast enhance as well. And treatment is gross total resection when possible. Adjuvant radiotherapy can be used if there's residual tumor, usually up to 54 gray of external beam radiotherapy to improve local control. And generally, prognosis for the spinal ependymomas is better than the intracranial ones, but obviously depends on kind of location and extent of resection. And that's all I have for you today. Thank you, everybody.
Thank you, Damien.
Okay, I believe I'm next, so I'll pull up my presentation.
That's correct.
Okay. So hello everyone. My name is Jakob Tiefenbach. I'm a graduate from the University of Edinburgh and Imperial College London in the United Kingdom, and a research fellow at Cleveland Clinic, Ohio, and a Match 2024 applicant. I have the pleasure of visiting the department for a few weeks, and today I'll be presenting a fraction of my work done at Cleveland Clinic titled Dentate Nucleus DBS for Stroke and Traumatic Brain Injury, Optimizing Stimulation Parameters. So our lab is developing a novel DBS therapy for stroke and traumatic brain injury. To tell you more about this therapy, I first need to tell you about the dentate nucleus. Dentate nucleus is the largest cerebral nucleus and an important component of the dentothalamocortical pathway. The dentothalamocortical pathway that you can see on the right represents a large neuronal network originating in the dentate with projections to multiple thalamic nuclei and from there to the cortex. So our lab has shown that chronic electrical stimulation of the dentate nucleus enhances recovery in rodents with stroke and traumatic brain injury. We've published extensively on this, with the latest paper published as recently as September 2022. Even more recently, we have shown that and replicated these results in human subjects. And phase 1 clinical trial of this work were published just a few weeks ago in Nature Medicine, and the phase 2 clinical trial is currently in progress with our team actively recruiting patients. However, one of the big challenges we have is optimizing stimulation parameters to achieve maximal benefit for these patients. So there is a range of stimulation parameters that can influence the outcome of DBS treatment. Stimulation properties such as pulse width, pulse amplitude, stimulation frequency are all crucially important. Also in human subjects, active contact selection and choosing which contact the stimulation is going to be delivered through is also paramount. And optimizing stimulation parameters for our novel therapy presents a unique challenge. So for Parkinson and essential tremor, which are common DBS indications, patients will experience acute improvement. And you can use their acute symptom relief as a way of optimizing stimulation parameters. However, for our novel therapy for stroke and traumatic brain injury, it takes months or even years for patients to see significant benefits. And therefore, there's a need for us to identify a biomarker that will help us guide parameter optimization when the lead is implanted. And importantly, and this is a very important slide for the rest of the talk, we understand that the extent of cortical activation that can be achieved by dentate DBS may be a valuable biomarker to guide parameter optimization. As you can see on the left, again, the dentate has projections to the cortex. And when we stimulate the dentate, we induce cortical activation. And it is this cortical activation over a chronic period of time that leads to cortical neurogenesis and therapeutic recovery that we've shown in our lab. So really, cortical activation is a very important step in this therapeutic cascade, making it a good biomarker for us. We assume that if we can maximize the cortical activation, the patients would achieve the greatest benefit. So with this in mind, I developed a methodology to measure cortical activation in response to dentate stimulation in animal model. And I can really take full credit for this work. It takes 5 steps. I first implant an electrode into the dentate. I then confirm that the electrode is actually in the dentate. I then train the animals for MRI acquisition, and then I acquire and process functional MRI and MR spectroscopy images, which give me an estimate of cortical activation. And I'll take you through this methodology. So first, I put the microelectrode is implanted. I use a platinum iridium microelectrode and place it with the stereotactic frame. It's usually placed posterolateral to the lambda. Then I confirm that the microelectrode is at the right place. I do this through side effect thresholding, which is a process of increasing the amplitude of current delivered through the electrode until side effects are noticed. And if I'm correctly stimulating the dentate, I'll notice front paw shaking in these animals. And then I need to train these rats for MRI acquisition. And acquiring MRI in awake rats was really essential for us to ensure accurate findings that can be translated to human subjects. But this is methodologically challenging, and very few groups have done this. And I'm incredibly proud to say that I've developed a device and developed a patent which facilitates this type of research. And once these animals are trained with the use of the device for MRI imaging, then I acquire functional MRI while also delivering current to the dentate nucleus. I use a block design fMRI method where I map the changes in blood oxygen consumption between the off and on stimulation conditions. As you can see in bottom left. So as I acquire the scan, we alter between the off and on stimulation conditions. And to support this work, I had to develop quite a robust methodological paradigm on bottom right, which allows us automized delivery of electricity to the animal with simultaneous fMRI acquisition. And then I pre-process these images and work with these images, and we get something like this. So we actually can see visually the extent of cortical activation and the level of activation. Here I'm showing an example of 2 rats. One was stimulated at 130 microns, one at 80 microns. And in both of them, we can see a level of activity in the cortex. And it's more significant in the one that was stimulated at 130 microns. I also acquire MR spectroscopy while delivering current to the dentate nucleus. This allows me to quantify the metabolite concentrations in the brain. And importantly, we understand that for our purposes, glutamate and NAA can be considered as markers of neuronal activation. So I acquired 2 scans, one with stimulation and one without stimulation. And I get an output when I analyze the data, something that like the one in bottom right. And then this is some proof of concept data, but then I can use these changes in this molecules as a way of assessing and measuring cortical activation. So here I can see you can see when I place the voxel and focus on the prefrontal cortex, with stimulation, there's quite a spark increase in NAA and glutamate, which tell me that the neurons in that area are more activated. With motor cortex, we see a similar pattern, although maybe not as pronounced in this sample. And now the future and the next step is to correlate these MRI-based metrics of cortical activation that I've developed to the treatment response. So ideally, we'll have 3 groups of animals, those with high cortical activation, those with moderate, and those with low cortical activation. And then we'll see how they're different in the way they respond to the treatment. I hypothesize that those with high cortical activation will achieve the best response to treatment. And if this proves correct, this method can be translated to humans and further used as a tool for dentate DBS parameter optimization. So our novel therapy and its initial programming could be guided by fMRI and MRS, and kind of changing the paradigm as how these things are programmed. And I want to acknowledge a lot of people that helped to support this work. Dr. Andrew Machado is my primary mentor, and this work was done in his lab. Dr. Michael Steinmetz he's a chair at Cleveland Clinic, and he's been a tremendous source of support for me. And then Dr. Andreas Dimitriadis, who is the president of the European Association of Neurosurgeons and my first mentor. I also just want to highlight some other research that I've done in the lab. I had an opportunity to develop quite robust skills in signal processing. I've been working a lot with image processing. I've developed some phantom-based experiments and models, and I've done a lot of clinical work I'd like to highlight the Lancet publication where I'm the first author. Had the chance to publish a fair amount, and almost half of my publications are first author, which I'm incredibly proud of. Thank you so much. I'm happy to see everyone around these few weeks and would be very happy to take any questions either now or when I see you in the OR. Thank you.
Very nice. I think we're going to have to hold questions for everyone until later. Next up, we have Dija.
Thank you, Dr. Landy. I'm sharing my screen now. Okay, I'm ready. So good morning, everyone. My name is Deja Rush. I'm a fourth-year medical student at Howard University, and I'm currently doing my sub-I here at Miami. And I'm presenting my grand rounds presentation today on a research project that I've been working on with my mentor, Dr. Damaris Fawcett, on the assessment of the impact of laminectomy with or without instrumented fusion on ambulation in a majority-minority geriatric population. And so just to give some context into the motivation behind this study, the sudden or gradual loss of mobility and a potentially increasing sedentary lifestyle can be extreme sources of fear and anxiety for elderly patients. And their ability to ambulate is typically uniquely tied to their independence and freedom and ability to maintain a healthy lifestyle. And so loss of control over that major aspect of their life can lead to the onset or exacerbation of a plethora of medical and mental illnesses. So essentially what we wanted to do with this study was assess how effective laminectomy with or without fusion can be on improving ambulation in this population. And we went about doing this by developing a grading scale that is reproducible and can be easily used in the clinical setting to be able to objectively look at the ambulation status of geriatric patients undergoing spine surgery. And so for the methods here, we did a retrospective study of our patient population between January 2014 and December 2022, maximum follow-up of approximately a year. And so all of the surgical procedures took place at Howard University Hospital by our sole neurosurgeon, Dr. Fawcett. And essentially all of the patients underwent this specific procedure. And the only real inclusion criteria was that they be at least 65 years old at the time of surgery. And then the primary outcome that we were looking at was the grading scale that I mentioned. And this was really used to capture the general various levels of ambulation, with 0 points being bedridden, and then 1 needing to use a wheelchair, 2 walker, 3 cane, and then 4, the highest score being ambulatory without assistance. And so for our patient demographics, approximately 106 patients met the criteria for this study, and some of them required reoperation, which is why you'll see that we studied 115 or analyzed 115 surgeries overall. The mean age at the time of surgery for this group was about approximately 71, and there was a pretty even distribution of men and women. Interestingly, the overwhelming majority of the patients, so over 80%, identified as African American, which is not something that you commonly see in neurosurgical research studies. So that was interesting. And then also the fact that many of our patients possess a government-funded insurance, either Medicare or Medicaid, as their primary health insurance. The average BMI was in the normal range, and so a lot of our patients outside of the scope of this study are overweight. But for these patients specifically, I think with age and the natural process of aging, a lot of patients experience wasting and loss of weight over the course of their life. And so the final bullet point shows some of the chronic illnesses that were the most prevalent in this group that we looked at. And so the top 3 being hypertension, dyslipidemia, and then diabetes. And so on this next slide, I kind of talk about the etiology of the reasons why patients sought out surgery in the first place, and then the location of the actual procedure that they required. So in about 1 in 5 patients, the etiology of their pathology was trauma. And so falls, central cord syndrome, and then with 12% of patients, the etiology was cancer. And so we saw a lot of patients with multiple myeloma, and then also metastases to the spine, specifically cancers such as prostate cancer, which is very prevalent in African-American men. And then you can see the percentages that I listed here for the region of the surgery that the patients received, over half of them being in the lumbar region, but also a fair number being in the cervical region as well. And then so for the postoperative course and complications, you'll see the average length of stay for our patients is quite long. It's approximately 2 weeks. If you take out the outliers, it goes down to about 10 days, but that's still quite long. And so the reasoning behind that is we have very sick patients that require complex medical management and longer stays in the hospital. And then the other being that because of the insurances that our patients have, we have a very hard time in being able to get them admitted into acute rehabilitation centers. And so we always try, and a lot of paperwork and going back and forth. And with that struggle, we end up having to go with Plan B, which is having them go to subacute, LTACs, SNPs. And so that's why you see a large percentage of patients were discharged there and versus a little over half were discharged home. So the average follow-up was approximately 4 months, but we use the typical follow-up windows that you'll see in surgical research studies, 6 weeks, 3, 6, 9, and 12 months. And then I want to explain that 14 of our patients were completely lost to follow-up, but 14 patients, even though another separate 14 patients, though they didn't return to neurosurgery clinic specifically, they returned to the hospital for other medical reasons, whether it be to the ER or following up with cancer treatments or such. So we were able to look at that documentation to ascertain what their ambulatory status was at that time. And then in the final bullet point, we had 11 postoperative complications. So 3 wound dehiscences, 2 CSF leaks, 2 post-op deaths. The post-op deaths were unrelated to the surgery. Those patients just were very sick and had very complex medical illnesses that caused them to expire. And for the wound dehiscences and CSF leaks, those were treated and ultimately did not affect the long-term ambulatory status of those patients. And then for the rest, most of the patients simply presented with sanguinous or serous sanguinous drainage from their wound site that resolved on its own and closed up. So getting into the meat of the presentation, talking about the FR scores. And so I want to let you guys know that I'm presenting the final scores on these slides. So however long the patients followed up with and looking at the averages across those groups. And so in this first one, I'm comparing the different regions that the patients receive their operations in. And so you can see in this trend graph here that on average, the patients who received surgery in their lumbar region had much higher scores. So on average, so 3.25, so anywhere between walking with a cane versus ambulating independently. And then you'll see that the lowest scores were patients that required an operation in their thoracic region, which makes sense with what we know about the canal being typically narrower and the susceptibility to vascular compression and things like that. And with the non-parametric statistical test that we ran, we did see that there was a significant difference across these regions. And then so similarly, final FR scores again, but this time based on the source of pathology. So cancer, trauma, and then those who received elective surgery for things such as degenerative disc disease or spinal stenosis. On average, the patients that got elective surgery did much better. You see their scores pretty much at a 3, which is about walking with a cane, versus those who suffered from cancer or had some sort of trauma. Those patients are between a 1 and a 2, which is between using a wheelchair and then using a walker. And again, there was a statistically significant difference across these 3 groups. And then for slide 3, I know this slide is a little on the busier side. And so essentially what we were looking at was the different comorbidities that I outlined earlier, seeing whether if a patient had that comorbidity or didn't have that comorbidity, was there a statistically significant difference in their final FR scores? And you'll see at the text box I have at the bottom that for those with type 2 diabetes, cancer, and some sort of psychiatric illness, so schizophrenia and depression, that there were statistically significant differences. And so for diabetes and cancer, it was more so that if the patient had that comorbidity, then their scores were typically less on average. But then for psychiatric illness, for some reason, if the patients had that, they did better. So I don't really know what that's about. As you can see, they actually have the highest scores of any of the groups there. So that was interesting. And then so for this slide, this is again comparing the final FR scores, but across the different insurance statuses. So you see that the patients that had no insurance at all, their scores were on the relatively low side, were very low. So between either being bedridden or needing to use a wheelchair. But there were only 2 patients that had no insurance at all. So that's why it likely didn't create any sort of rift in terms of the statistical significance for this data. And so when you're looking at the bulk of the groups, so the Medicare, Medicaid, and private insurance patients, you'll see that the final FR scores are essentially very similar. And I think that goes into the fact that the mission statement of the Howard University Hospital is all about serving the underserved. No matter your financial status or your ability to pay, you're going to receive the same level of care. And I think this slide really reflects that. And so this one goes back into talking about the final FR scores for patients that were discharged from versus going to rehabilitation. So as I said before, a lot of our patients end up having to go to subacute rehabilitation centers or SNFs or LTACs. And those facilities tend to not have a lot of resources. Patients have a very difficult time getting their physical therapy on a regular basis, procuring transportation to be able to come to follow-up appointments. And so they usually have a lot of complaints when we actually do end up seeing them in clinic a long time a ways. And so you actually do see a statistically significant difference between the groups that were discharged to rehab versus going home. And then, so this is my final slide on the FR scores. So this is just looking at the follow-up windows that I discussed before, and then comparing that to the baseline preoperative score. So you'll see that preoperatively, the patients, they were typically about a 2.66 on average. And then you see quite a bit of a drop off, a statistic that was statistically significant at disposition. A lot of the patients are in pain and they're very cautious and hesitant to get up and walk around. So it's likely why you see that big difference. And then there is a large difference here when you jump back up into 6 weeks and 3 months, and you start to see some progress and improvement there. And I have on the left which of the values were statistically significant when you're comparing them. But then you also see a drop off at 6 months, which we have 2 theories as to why that likely is. The first being that a lot of our patients are stubborn and don't like going to the hospital and don't like following up. And likely at 6 months, they reach their limit and are like, okay, I'm going to come and figure out what's going on and figure out how I can get better. And we finally see those patients for the first time. And then our other groups of patients, they come to follow up for care initially, and then they go to physical therapy, and then they don't continue with their exercises at home. And so when they come back to clinic, they start to lose some of those gains that they originally saw in physical therapy. So for both of those groups, we give them their medications, send them back to physical therapy. And that's why you see the scores climb back up and plateau around 9 and 12 months, which is the time that most people will reach full neurologic recovery. And then with the pre-op versus the final, so just looking at all of the patients combined, you'll see that also that there really wasn't a large difference, 2.66 versus 2.76 for the final FR scores for both of those groups. And so in conclusion, we found that in general, ambulatory status does not improve for geriatric patients after undergoing laminectomy with or without instrument diffusion. You'll see that obviously there are some nuances to that based on insurance status, how they are discharged, and the different comorbidities that they have. So that data and information can definitely be used for guiding decision-making in regards to whether this will actually be helpful for a specific patient. And then my second bullet point here just shows that possibly just assessing how this specific surgical procedure helps with pain and how that relates to the patient's quality of life may be a better metric to study in the future. And with that, that is all. And thank you all for your time and the opportunity to present. And I hope everyone has a good day.
Okay, thank you. Next is Hal.
Hey, how's it going, everyone? Hope everyone can hear me. Good morning. It's a pleasure to be here. For those who haven't met me yet, my name is Hal. I'm a student from OHSU, Oregon Health and Science University over in Portland, Oregon. Had a fantastic time rotating here as a sub-I, and I'm stoked to share what I've been working on. So I like to take a year off between my third and fourth years of med school to do cortical electrophysiology work with my mentor, Dr. Ahmed Roslan, and Alex Rockhill, a postdoc. And our research group is interested in exploring the neural correlates of human cognition, essentially what makes us the way that we are. And kind of underneath this broad umbrella, I'm personally interested in human symbol conception and comprehension. Essentially our ability to create audiovisual shortcuts for kind of day-to-day concepts. And over this past year, I specifically explored this through the lens of human number cognition. So before I go further, I just want to kind of define numerical cognition, which I think can really be boiled down to the ability to process and understand the numerosity of things around us. And this capacity isn't unique to us as humans. It's actually phylogenetically conserved across different species. Animals know when to run away when they're outnumbered, or attack, when the numbers are in their favor. But what is uniquely human is this ability to represent real world quantities through symbolic representations, such as words and numbers that we can efficiently recognize and understand. And from kind of fMRI and TMS studies, modern neuroscience has kind of come up with a neuroanatomical explanation for this in the form of the triple code model, which postulates that different number representation formats are encoded by different brain regions. So for example, the intraparietal sulci encodes our ability to make sense of non-symbolic real world quantities. So for example, when you see 6 dots, you just know, hey, that's 6. The parasylvian regions are responsible for our ability to make sense of the word 6 when we hear it and see it. And the ventral temporal lobe is responsible for processing our ability to understand Arabic numerals. And while the triple code model is a lot better and more substantiated than previous models of human number cognition, there's a lot to be desired. And to really build a more refined understanding of human number cognition that counts not only for anatomy, but electrophysiology as well, we investigated human number cognition through leveraging stereo EEG recordings, which allowed us to sample a broad array of intracranial sites, including subcortical ones beyond kind of the canonical regions, if you will, involved with number processing that I talked about a little bit earlier. So over this past year, I enrolled 13 stereo EEG patients who were undergoing epilepsy monitoring at my institution's EMU, and I presented them with a simple number recognition task. And so these patients were presented with a series of random number stimuli inspired by the triple code model's postulates that differed by the method of stimuli delivery. So whether it was delivered visually or auditorily, and representation format kind of shown there in the slide. And I also have a schematic of our task. So we present the numerical stimuli with intervening 2-second long trial rest intervals. And to really identify stereo EEG contact locations and electrophysiologic features of interest, we classified cortical activity captured during these number trials against the intertrial rest period. And to really do this, we used the principal component analysis to dimensionally reduce the captured stereo EEG recordings before passing them into a support vector machine classifier. And to just kind of expand on what exactly we're doing, so the PCA, the principal component analysis, essentially dilutes down the high dimensional stereo EEG data into components that still retain useful trends and patterns while kind of removing a redundancy and artifact. And then we use the most important or principal components for classification purposes in our SVM support vector machine classifier, which classifies features between our 2 experimental states, which in our case is the number trials versus the intertrial period, by finding a best fitting 3D line, which they call a hyperplane. And once we go through this process and cross-validate our data, we're able to obtain classification accuracy outputs for our siege contact locations and spectral activity patterns. So just jumping into our results, we began first by looking for anatomic correlates of number processing using the classification accuracy and location of stereo EEG contacts. So here we have some histograms showing the number of contacts with significant predictive values shown in kind of the salmon red hue across their different number representation conditions. And really what these histograms suggest is that not all brain regions sampled by the stereo EEG contacts have significant classification value and by extension are engaged when presented with a number stimuli. Sorry. And using the location of contacts with significant predictive accuracy, we were able to parse out brain regions and build a classification accuracy heat map across cortical and subcortical sites. So here we show the results from classifying all number trials, kind of regardless of representation format, against the intertrial rest period. And we can see that the posterior parietal regions had the highest accuracy in the cortex, while the putamen had the highest accuracy in the subcortex, suggesting that these sites were more preferentially engaged during the number stimuli, again, irrespective of representation format here. And when we went back and looked at individual contacts with the highest predictive value, we saw similar evidence for parietal cortex engagement, as well as activation within the temporal lobes. Then we assessed whether anatomic correlates differed by whether they were delivered auditorily or visually. So here we juxtapose accuracy heat maps for auditory versus visually delivered stimuli. We see here that the superior temporal and inferior parietal cortices had higher classification accuracy and were more engaged during auditory trials and visual trials, which makes sense. And additionally, during auditory trials, interestingly, both putamen had comparably strong engagement, which was not the case during visual trials. And then we tried to make even more granular distinctions to see if the representation formats, the 5 different ones, could be distinguished by anatomic regions alone. And between the auditory formats, it seems like the increased right putamen and inferior parietal engagement were characteristic of spoken number and sequential beat formats, respectively. But we couldn't really tease anything apart between the visually presented formats, at least until we compared the spectral features between the visually presented number stimuli. So it's kind of a big, busy figure, but what we show in this figure is that the top row provides sort of an average spectrogram for all number trials within each given number representation condition. The middle row shows whether the frequency bands with the highest power in the average spectrograms increased, shown in yellow, or decreased, shown in blue, relative to the intertrial rest period. And finally, the bottom row shows the predictive value of these power changes. So Arabic numerals were characterized by an early theta increase. Dots had a smudged theta through beta increase, while written numbers were characterized by a slightly delayed uptick in gamma activity. So in summary, we identified anatomic and electrophysiologic correlates of basic human number cognition using stereo EEG. This is actually the first study to do it, and we really show both the anatomy and electrophysiology of the human brain on numbers, if you will. And our findings align pretty well with existing number cognition models and prior fMRI data, while also kind of going a step further and affirming that it's not just the anatomy that matters, but also the electrophysiologic changes as well. And I think really our findings provide points to potentially improve our contemporary understanding of human number cognition. We show that subcortical regions have a role, such as the putamen, for example, whose significance is not emphasized by prior number cognition models. And finally, our analysis suggests that assessing a variety of frequency bands may be critical for making more nuanced distinctions between representation formats. And moving forward, I want to continue bridging neuroanatomy and electrophysiology in the context of human number cognition by taking a closer look into how intracranial sites interact with one another. In particular, I want to better understand any potential interplay between cortical sites and the putamen. And I want to do this because it may actually help provide some clarity to some intense debate within the social science and developmental psychology literature over whether our ability to process numbers is linked to our language capabilities, especially as the putamen has been implicated as a key player in language processing as well. And so finally, I just want to thank you all so much for your time. I've had a tremendously positive experience rotating here. And I want to extend, once again, a big thank you to all the residents and faculty. And with that, I'd be happy to take any questions later. Thank you.
Thank you. Very nice. Next is Seema.
Hi, everyone. Thank you, Hal. It was a really great presentation. Tough act to follow. But let me put on presenter mode. Okay, my name is Seema Vasquez. I'm a fourth-year medical student at New York Medical College, and I've been doing my sub-I here. Really want to thank the department, all the residents. It's been a really, really formative experience. So just a lot of gratitude for this time here. But I'm excited to present this systematic review on treatment of Chiari malformation and craniovertebral junction anomalies. Where do we stand today? Just for some background, I want to prime this presentation by kind of highlighting the diffuse definition or non-definition, if you may, of Chiari that we have throughout the literature in our textbooks, such as Greenberg. So it's defined as like a heterogeneous entity. There's a common feature of impaired CSF circulation. There's cerebellar tonsillar herniation, but criteria varies. Greater than 5 millimeters below the foramen magnum is often cited, but neither essential nor diagnostic. And then treatment, when indicated, is controversial, and aspects of what the surgery should entail have been debated. And then craniovertebral junction anomalies, we know that up to 74% of patients with a Chiari-1 also have a junction anomaly. And these include, but of course are not limited to, basilar invagination, platybasia, or some atlantoaxial dislocation or instability. And these patients may have, on top of Chiari symptoms of headaches, but also like cervical and occipital pain, instability at the junction that may be causing other problems. So it poses really a population of interest to study that's very different than a population with just an isolated Chiari or cerebellar descent. So our objective was to systematically review the literature and evaluate the trends and outcomes for surgical interventions for this specific population of patients with Chiari and junction anomalies. So these were our methods. It was a standard systematic review with PRISMA guidelines, pretty standard search terms. And then our inclusion criteria, again, we really wanted to hone in on this population that has both pathologies. And then we wanted to make sure that the surgical intervention was described in the paper. Our exclusion criteria was, again, pretty standard. At the end of our abstract screen and criteria application, we ended up with 12 articles. Publication years spanned from 1998 to 2020, so a very wide range. And interestingly, 11 of these 12 papers were retrospective reviews, and only one of the 12 papers had a prospective study. So I think that already points us in the direction of thinking that we may need some more prospective studies looking at this population. But in total, we had 449 patients throughout all 12 articles to analyze. These are some of the general results of the reported junction anomalies throughout the papers, mostly basilar invagination at 75% of the patients, but also atlantoaxial dislocation, odontoid process retroflexion, what some of the papers refer to as medullary kink, and then a multitude of either combined anomalies or different singular ones. And I have some pictures of them below. And then for the symptoms that the patients presented with, again, very wide variety, but I highlighted some of the ones that presented in most of the patients. So mostly weakness, extremity weakness, and then some paresthesias, occipital and neck pain was also a big one, and then ataxia. This is a busy slide, but I will take us through it and break it down a bit. I want to start with the population studied column. So all of these papers studied Chiari with basilar invagination, and then plus or minus a variety of different either compression or a ventral component or dislocation instability. And then as it's a systematic review, there's of course selection bias. So all of the papers had favorable outcomes that they reported. And then if we move to the left of the slide here where the timeline is, I think this is really the bulk of what we're trying to analyze in our trends. So early on in 1950, the patients were undergoing posterior decompression, just singular posterior decompression. And then as we move on to 1984, we started to see some anterior decompression, like transoral approaches with posterior stabilization. And this was mostly occipital cervical fusion that we see. And then if we keep moving on down the timeline, we see some posterior decompression with stabilization. So moving away a little bit from the anterior decompression, but still occipital cervical fusion. And then later in the 2000s, we start to see a trend towards posterior stabilization without any decompression. So no posterior fossa decompression and just posterior stabilization. And interestingly, this is at the C1, C2 level that was reported. And then there's one paper in 2012 that goes over a cohort of patients who failed posterior decompression and required a C1, C2 stabilization later on. Of note, in 2010, for these posterior stabilization without decompression papers, 3 of these 4 papers are published by the same group, and we'll go into that in a little bit. So just overview of the main findings of our systematic review. So posterior fossa decompression appears to be the most accepted treatment throughout the years. There's still papers published later on, but it was the one that came out earliest as well. Ventral decompression has seemed to lost favor, at least it's not published as widely as it was before. There's high morbidity associated with the ventral decompression. And then primary or salvage posterior arthrodesis is becoming more widely accepted and more widely published. And we can go into a little bit of why that may be. So really, this review brought up the question of is fusion necessary or not in these patients? And it may be that some of these patients with anomalies may require stabilization as an adjunct to posterior fossa decompression. There may be instability present, and correction of the malalignment can further indirectly decompress the tonsils in the brainstem if there is compression. And then the one paper that highlighted failed posterior fossa decompression requiring C1, C2 fixation later on may highlight the need for long-term follow-up in these patients, especially if they're undergoing decompression early on in childhood, like pediatrics, maybe long-term follow-up into adulthood. And then also highlights a difference between symptomatology in compression versus pain, whether they're presenting with like cerebellar tonsil or brainstem compression symptoms, or like occiput and neck pain from maybe a deformity or the anomaly. To highlight some of the key like populations that we see throughout these 12 articles. So this is by Goel, and this is the group that published 3 of those 4 papers that stated that decompression was not necessary in these patients. And this one, interestingly, is in a cohort of patients with basilar invagination Chiari, but without obvious atlantoaxial instability. And so they still fuse at the C1, C2 level, and it's again selection bias. So there's like favorable outcomes in these patients, and resolution almost of the syringomyelia just with the fixation without any posterior fossa decompression. In this paper, in the discussion, they actually state that this may be a formidable approach for any patient with CM1. And so there was a response to this paper by the Pediatric Cranial Cervical Society, just highlighting that this population had a high representation of craniovertebral junction anomalies and large syrinxes, and may not be applicable to a typical CM1 population that has no associated craniovertebral junction anomaly. And this kind of highlights a point of there's somewhat of a lack of validation and standardization of these different metrics of what we're calling craniovertebral junction anomalies throughout the literature. Some of the papers used different thresholds for instability, and many of the papers didn't include radiographic evidence for these definitions. And then again, to highlight this paper by Goldstein, just stating that the prevalence of CVJ instability and need for stabilization is likely skewed by studies from centers that are known to specialize in these populations, and maybe extrapolating their results to a general population. Just to go over some of the objective radiologic measurements that can help us define the dynamics at the CVJ more objectively, we often can use the clivo-axial angle that we see highlighted here. The PBC2 angle can also be helpful to look at some ventral compression, and then the atlanto-dental interspace to see if there's any instability. This is the paper I also wanted to highlight that shows the failed posterior fossa decompression in patients who then later required C1, C2 fusion. And then just to note that all of these patients did have atlantoaxial dislocation. So it points to my next slide, which is where does this really leave us? There's a question that we see throughout the literature of if stabilization is necessary or fusion is necessary, what is the level that's appropriate, whether it's OCF or C1, C2. The newer papers seem to favor C1, C2, but again, they were saturated by 1 or 2 authors. And then it really points us to highlighting and honing in on different populations that may benefit from either OCF or C1, C2, and which population, what etiology of the cerebellar descent is going to be most benefited by the different levels. It also brings us to the question of many of these patients may be presenting in pediatric years. So is fusion or stabilization even possible at the time of their initial presentation? And if so, is it something we would want to think of later on after the posterior fossa decompression? Of course, it's a very heterogeneous population that sometimes gets lumped together. So maybe are all craniovertebral junction anomalies created equal? Do we need to be a little more specific in the populations that we're studying? And as I said, 11 of the 12 articles were retrospective studies. So really highlights a need and a potential space for more prospective studies that differentiate these populations, specify the etiology of the cerebellar descent, and really identify the cause of pain and symptoms that the patients are presenting with. Some of the limitations to highlight, again, mostly retrospective data, a lot of selection bias with favorable outcomes, and the overall arching theme of heterogeneous patient populations and the need to better define and hone in on our selections. There was also no direct comparisons of fusion with or without posterior fossa decompression. We either saw papers who did both or papers who did without posterior fossa decompression and just atlantoaxial. And then it brings us kind of an overarching broader question of how to interpret literature that may be saturated by a few authors in different countries, and how do we take it all together and apply it. So these are some of my references. And again, I'd like to thank everyone here for their generosity in welcoming us as sub-Is. It's been a really great experience. Here's my email if anyone has any questions later on.
Great. Thank you very much. Finally, we have Elsa.
Alrighty, so good morning, everyone. My name is Elsa Nico, and I'm a fourth-year medical student from the University of Illinois, Chicago. First off, I'd really like to thank everyone for welcoming us and giving us an incredible sub-I experience here in Miami. So today I'll be discussing one of the projects I completed during my research year at Barrow under the mentorship of Dr. Michael Lawton. This project assessed the relationship between surgical timing and post-operative seizure outcomes in 63 patients with cavernoma-related epilepsy. So I'd like to set the stage with how I brainstormed this idea. When it comes to research, I'm often motivated by the lived experiences of my family members, my friends, or patients, especially those from vulnerable populations. So this is a picture of me and my cousin at his graduation this past May. Here he is again, and that's one of his best friends, Tate. So Tate went into status epilepticus this past December, which was, of course, a terrifying experience for him, his family, and my cousin, who had to take control of the car when it first started, and throughout the hospital admission, as he periodically called me for advice. Well, in Tate's situation, he's completely okay now. The diagnosis at the time was febrile seizures, secondary to a combination of RSV, the flu, and the common cold. So for him, those seizures were probably just a one-time event, but not every patient is as lucky. A lot of patients may develop epilepsy depending on the etiology of the seizures. And epilepsy can significantly affect a patient's quality of life, including their physical well-being, their mental health. They can cause cognitive impairment like anxiety and depression, affect their relationships, limit their education and employment opportunities, as well as take away their driver's license and independence, and finally can be quite a financial burden. So what exactly did Tate's seizures inspire me to look further into? Well, of course, working with Dr. Lawton meant I became more and more familiar with cavernous malformations and their natural history. So CAV-MALs are the second most common cerebrovascular malformation after AVMs, accounting for 10 to 15% of malformations with an estimated prevalence of 0.4 to 0.8% in the general population. consisting of thin-walled dilated blood vessels lined with endothelial cells, lacking intervening tight junctions and mature vessel components. Cab-mouths form caverns, which are filled with blood at various stages of low flow and thrombosis. And though they appear as dark reddish-purple mulberries on gross inspection, as depicted in the image on the left, they're termed angiographically occult due to their low flow circulation. So thus, the diagnosis often relies on MRIs, as seen in the image on the right, depicting a pathognomonic popcorn lesion surrounded by a T2 hypointense hemosiderin ring of blood products following multiple small hemorrhagic events. Now, seizures are actually the most common presentation of supratentorial cavernous malformations, accounting for 15 to 40% of initial presentations, rendering supratentorial cav mals the most epileptogenic cerebrovascular disease. These lesions may induce seizure-like activity as a result of hemosiderin deposits, inflammation, and gliosis. So given that the risk of recurrence after a first-time seizure can be as high as 94% over 5 years, international guidelines recommend either conservative management with an anti-epileptic drug or AED, or microsurgical resection as first-line treatment options for new onset cavernoma-related epilepsy, or CRE. CRE is defined as epilepsy in patients with a cavernous malformation and EEG evidence of seizure onset near or at least in the same hemisphere as the cavernous. Now, even though most CRE patients are initially conservatively managed, AEDs harbor unwanted adverse effects, and up to 40% of patients develop drug-resistant epilepsy, or DRE. DRE is defined as persistent seizures for at least 2 years while on at least 2 different AEDs. Numerous studies, on the other hand, have demonstrated seizure freedom in approximately 75% of CRE patients undergoing surgical intervention as definitive treatment. However, despite the overwhelming evidence of seizure control efficacy, surgery is often reserved only for refractory status epilepticus, or DRE. This led me to ask, how do the rates of seizure freedom and AED independence at follow-up compare in patients with CRE undergoing early versus delayed surgery? So to answer that question, we retrospectively reviewed our surgically treated CAV-MAL database of 337 patients from January 1st, 2010 through July 31st, 2020. Patients who did not present with seizures, had multiple or familiar CAV-MALs, had a prior surgical resection or recurrence, or had a follow-up that was less than 1 year were excluded from the analysis. This yielded a total of 63 patients with CRE that were included. These 63 patients were then divided into 2 groups according to surgical timing relative to the pre-op CRE duration. There were 48 patients in the early or less than or equal to 6 months group and 15 in the delayed or greater than 6 months group. Patient charts were reviewed for demographic information as well as clinical characteristics and SCM features. Primary outcomes were defined as seizure freedom, ILAE class 1, and AED independence at follow-up. Patients who either discontinued or were never started on AEDs were classified as AED independent at follow-up. So for the overall 63 patients with cavernoma-related epilepsy, the mean age at presentation was 36, and a majority were white males. The most common lobe involved was frontal, followed by temporal, parietal, and occipital. Most patients had cortical involvement and a favorable pre-op functional status. The mean pre-op CRE duration was 19.5 months. 46 or 73% of patients were on an AED preoperatively, of which most were on a single AED and primarily on Keppra, compared to other AEDs such as Lamictal, lacosamide, Depakote, and Dilantin, among others. And the mean follow-up was 5.4 years. So as previously mentioned, 48 or 76% of patients underwent early and 15 or 24% underwent delayed surgery. All demographic and CAV-MAL characteristics were comparable between early versus delayed surgery groups. Even though there was a predetermined 6-month cutoff for defining the 2 groups based on surgical timing, a wider gap in mean pre-op CRE duration was seen between the early versus delayed groups of 2.1 months versus 6.2 years, respectively. And 2/3 of the patients in the early group had a single preoperative seizure, whereas all of the patients in the delayed group had 2 or more pre-op seizures. Furthermore, all patients in the delayed group were on a preoperative AED compared to 65% in the early group. In the delayed group, 7 patients had drug-resistant epilepsy and 8 had chronic epilepsy. A greater proportion of patients in the early group demonstrated ILAE class 1 seizure freedom at follow-up in comparison to the delayed group. Similarly, significantly more patients in the early group were AED independent at follow-up relative to the delayed group. Despite no significant difference in the number of patients on AEDs at follow-up between the early and delayed cohorts, more patients in the delayed group were on follow-up AED other than Keppra and 2 or more follow-up AEDs relative to the early group. So once again, our study found that 92% of CRE patients who underwent early surgery after CRE onset achieved seizure freedom compared to only 53% in the delayed group. Since 1995, 9 studies have been published which support our findings, as they have demonstrated that a longer preoperative CRE duration is associated with worsened seizure outcomes. However, ours is unique in defining the time frame for early surgery as less than or equal to 6 months since catamenial-related epilepsy onset. So there are many benefits to early surgery for CRE. So over time, frequent seizure activity in CRE may worsen the epileptogenic focus with a resultant decrease in the rate of postoperative seizure freedom, which favors early surgery. Another benefit of early surgical intervention is the decreased likelihood of developing drug-resistant epilepsy, and thus an increased likelihood of achieving AED independence. And finally, residual hemosiderin deposits on postoperative brain MRIs have been significantly associated with poor seizure outcomes. Thus, early surgery should be pursued before hemosiderin expands in the surrounding parenchyma due to recurrent hemorrhages. So of the 38 patients on a single preoperative AED, 61% were on Keppra compared to 39% on a different AED. In the overall cohort, Keppra use decreased by 11%, while other AED use increased by 17% at follow-up. When stratified by surgical groups, patients in the delayed group were more commonly on a preoperative AED other than Keppra compared to those in the early group. The overall reduction in Keppra use amongst patients in either group at follow-up and the tendency to switch to a different AED over time suggests that providers may be overprescribing Keppra. Although guidelines supporting the use of Keppra as the first-line AED of choice in CRE management are controversial, possible explanations for using this medication include its favorable safety profile, its simple dosing schedule, fewer drug-drug interactions, and tolerability in pregnancy. So the main takeaway point is that early surgery for capnoma-related epilepsy may result in an increased rate of seizure freedom and AED independence at long-term follow-up. And thus, as neurosurgeons, we should be really advocating for our patients and recommending earlier surgery for these lesions rather than subjecting them to chronic management with AEDs. So these are my references. Lastly, I'd like to acknowledge and thank several people for their support on this project, including my mentors, Dr. Michael Lawton, and recent neurosurgery graduate, Dr. Josh Catapano, as well as my wonderful co-research interns, Dr. Ashia Hackett, who some of you may recognize as a former Black Lives Matter summer scholar, and Adam Eberly, my friends, and most importantly, my parents. So thank you so much. And again, thank you for a wonderful month here at Miami.
Hey, great job, Elsa. Alan Levy here. There's a little bit of a related question. And we discussed this on Grant M&M's often. Is it important to do a surgery that just involves removing the lesion and not worry about anything else to control the epilepsy, or is it important to do like an epilepsy surgery where you try to figure out where the actual seizure focus is? Because obviously the seizure focus is not in the cavernoma itself, it's whatever it's doing to the surrounding tissue, you know, with the hemosiderin deposits, or potentially even in a slightly different site. So I was wondering what your thoughts about that were.
Yeah, that's a great question, Dr. Levy. So I do know studies have shown it is important to get as much of the hemosiderin deposits that you see on imaging, not just the lesion, not just the cav-mal, because that can contribute to like that gliosis, the inflammation of the hemosiderin. But then when you're like running EEG studies to kind of determine where the epileptogenic focus is, and I guess if it's not, if it's like a little bit farther from the lesion, I think I would, my thoughts would be to first take out the lesion and the surrounding hemosiderin, and then see how the patient fares. I don't know if there have been studies or not on taking out more and including the epileptogenic region. but I do know when we're defining cavernoma-related epilepsy, we typically include patients that have cavernomas that are like 100% associated with epilepsy, like in that area of the cavernoma or in the nearby like hemisphere region.
Got it. Well, great job. And, this was a great segue to announce that, Dr. Lawton will be our Rossimoff visiting professor and will be coming here on November 10th and 11th. So if I still have a burning question about this, I'm going to ask him personally.
Awesome. Thank you.